So welcome everyone, and thanks for joining us for the Kirby Institute seminar series. So I'd like to begin by acknowledging the traditional owners of the lands which we gather today, which is the Gadigal people of the Eora Nation, and pay my respects to elders past and present, and extend that to Aboriginal and Torres Strait Islander people joining us today. So welcome everyone. A few housekeeping notes to begin with. So as you know, you've joined a live seminar, and the format for this seminar will start off with a presentation by Dr. Louise Causer, and then it'll be followed by a Q&A at the end. So to ask a question, hopefully we're all very familiar with this, but just a little reminder, you click on the icon with the speech bubble and question mark in the top right-hand corner to open the Q&A chat panel. You should be able to see that on your screens. And then when you click on the ask a question, please remember to write your name. This really helps us reference your question and makes answering the question a bit easier. Okay, so the topic of today's seminar is COVID-19 and healthcare workers. So a very timely topic. And I guess as we all know, healthcare workers have been on the front line of battling COVID, and I feel that they deserve our deepest gratitude and admiration for what they've done in terms of the COVID response. As we all know, they've put themselves on the path, in the path of this virus, and while caring for many vulnerable people in society. So Dr. Louise Causer will give a talk on COVID-19 and healthcare workers. She'll begin with a global perspective, but also focus on an overview of the situation in Australia, particularly looking at information from 3 states where healthcare workers have been affected by COVID-19. Most of you know Louise, but a little bit further information. So Louise is a medical epidemiologist. She's a senior lecturer at the Kirby Institute, and she's located in 2 programs, the CERT program and FIRB program. And Louise has a long-standing interest in the field of infectious diseases. Her more recent focus has been on sexually transmitted infections and integrating and scaling up point-of-care tests in remote communities in Australia, but also Papua New Guinea and other resource-limited settings. But since March, like many of us, Louise has been dedicated nearly all her time, and I would say even more, to projects supporting the public health response to COVID-19, with a focus on priority populations, including healthcare workers, which she'll be speaking about, and also point-of-care testing in remote Aboriginal communities. So with no further ado, I'll hand over to Louise, who will give her seminar on COVID-19 and healthcare workers.
Thanks very much, Beck, for that introduction, and I hope everybody can hear and see. I'd just like to take this moment to acknowledge the traditional owners of the land on which I'm presenting today, which is the land of the Cammeraygal people here in North Sydney, and pay my respects to elders past, present and emerging. So thank you again for the opportunity to present at the seminar today. And as Beck mentioned, I'll be presenting an overview of healthcare worker risk and infections, and touch on the importance and the impact of these infections amongst this most valuable human resource. So the outline of the presentation today will be a brief background and some perspectives from the global and also Australian perspectives, and then briefly touch on what might be in hold for the future. By way of background, I think there's no doubt that everybody would be aware of this, but as you'd know, the SARS-CoV-2 virus, infection with this causes COVID-19 and is transmitted by respiratory droplets and contact with contaminated surfaces. Airborne transmission is also considered possible, and there's been increasing evidence and discourse around the role that airborne transmission may play. And there are certainly well recognised circumstances in which airborne transmission plays a role, particularly with the aerosolisation of droplets through certain procedures that may be conducted in health facility settings. Transmission is certainly now well recognised to occur not only with symptomatic patients, but also from asymptomatic individuals. And as of, I think this is from Friday last week, The global number of cases is approaching 40 million, with over 1 million deaths worldwide. In Australia, as of that similar date, we've recorded and reported over 27,000 cases and just over 900 deaths. So to start the presentation, I actually just put in an internet search for what healthcare workers and COVID brings up, and there's certainly an ample supply of heartwarming and heartbreaking images of healthcare workers on the front lines, sort of early on in the pandemic and also more recently. And it just, I guess, highlights the strength and the capacity that we have in our healthcare workers and the importance that they play, as Beck's already mentioned, in protecting the community and our loved ones from infection and recovery. So we're also thinking about who are healthcare workers. I note that the WHO classifies healthcare workers as our most valuable health resource. Healthcare workers deliver care and services to the sick and ailing, but also prevent illness and disease in the healthy. Healthcare workers do this directly as doctors and nurses and allied health professionals who come in direct contact with patients and others, but also indirectly through aides and assistants and technicians, administrators and cleaners. So healthcare workers are not just those that immediately are providing clinical care, but also support for that clinical care. The WHO estimates that there are approximately 59 million healthcare workers worldwide, and that protecting the occupational health of these workers is critical to maintain an adequate workforce of trained and healthy health personnel. So why are healthcare workers particularly at increased risk? In their settings where they work, they're exposed to COVID-19 through patients and dealing with family of patients. They can be exposed in their hospital settings, but also in primary care and general practice and other community services that are providing care, and also specialist and health services and practices. Exposure may occur through the assessment and management of patients with known COVID-19, but also through the provision of routine care to patients and their families who may be unrecognised as having COVID-19. And thinking about acquisition of infection, it can occur through direct contact with patients or through indirect contact through handling of materials and objects belonging to patients. And they may be through the patients themselves, but also to recognise that colleagues and visitors and the public can also be a source for infection. And aerosol generating procedures that are conducted as part of patient care are recognised and considered as high-risk procedures. So increased risk in health facilities is present as a result of a number of factors, including ongoing and or increasing community transmission, which leads to additional patients coming in for care and diagnosis. There may be low threshold of suspicion or unrecognised infection for patients who are presenting with other symptoms or atypical symptoms. And particularly this is a risk early in the pandemic, I guess, where particularly in Australia, where numbers of infections were quite low in the community. And in health facilities, there's been a rapid scale up of specialist care services, including intensive care units and COVID-specific wards that puts people in circumstances where they might not otherwise be familiar. And there's also been a recruitment of perhaps less experienced or alternative experienced staff to fill gaps in the health workforce with the increased numbers of patients who are presenting to health facilities. So I'm sure a number of people would have read in the media and know about, you know, the early graduation of final year medical students in a number of settings globally, and being brought onto wards to help manage patients and fill gaps with furloughed staff. Retired staff brought back into the workforce who maybe have had a gap in clinical experience. And also the use of staff who may have less or perhaps inappropriate skills to fill gaps on wards or as frontline healthcare workers. There's also been the cohorting of COVID-19 patients, so sort of putting patients together in one place, so just increasing the density and the potential exposure that healthcare workers may have to COVID-19. And it has been reported as well that the over-referral of cases to health facilities, so perhaps people who might have been managed in the community or in their homes in the early stages may have been referred to health facilities for management. And so again, increasing just the density of exposure for healthcare workers in these facilities. So thinking about how healthcare workers might be protected and protect themselves in their workplace, I thought it might be helpful to consider what is a hierarchy of controls. And it's just an image from the Canadian Occupational Health and Safety website, and this shows the hierarchy of controls with a well described triangle with the most effective control measures at the top, down to the least effective at the bottom. And this is something I think that appears on a number of different websites. And this particular image I liked because it provides the explanation about the types of controls that might be put in place to protect a healthcare worker from COVID-19. The most effective being essentially elimination or substitution of the risk, where a worker may be able to avoid coming in contact with COVID-19 completely by working remotely. Engineering controls are particularly important because they provide things like physical barriers, changes in ventilation or filters, and also other approaches that eliminate or reduce the need for touching surfaces. Administrative controls include things about messaging, staggering work times and shifts, cleaning and changing practices, including physical distancing and hand hygiene and respiratory etiquette amongst patients who might visit. And finally, down the very bottom of the triangle is PPE, and I guess this is where a lot of the focus has been in thinking about healthcare workers and how they are protected. But this probably just gives a nice perspective on that PPE is just one of the number of control measures that might be applied to protect healthcare workers. However, thinking about those various control measures, health facilities and healthcare workers themselves, there may be a number of challenges that limit the application of some of those control measures in the professional settings. One of those being that for many healthcare workers, working from home is just not a feasible option. Physical distancing is also not always possible in a clinical setting, and in fact, health facilities are exempt from the 4 metre squared rule because of an acknowledgement of this. In engineering, the ability to manage or change engineering controls may be quite limited in some of these health facility settings, particularly older hospitals with perhaps poorly ventilated spaces. I guess the other component is that patient care can be unpredictable. Things don't always happen as you might expect, and as a result, healthcare workers may be in circumstances where they have to react quickly and may not be as well prepared as they could be. I mean, healthcare workers themselves no doubt have an incredible commitment to patient care and also to their colleagues, which may be a driver towards a pressure to attend work when perhaps mild symptoms or contact with perhaps a known case may not be the same incentive for a healthcare worker to remain at home and isolate. And there's certainly a component of long hours and extended work time that puts healthcare workers at particular risk, and they may not be, it may not be the same in other workplace environments. And there's certainly a sense of invincibility, I think, amongst some healthcare workers, thinking, you know, they are the last line of resort, and so they must be available to prevent and manage infection amongst patients. So thinking about how we might minimise risk with infection prevention and control practices. So this is much more focused on PPE and hand hygiene. So there's no doubt that risk for healthcare workers can be minimised through the adherence to these practices. And certainly the choice of PPE is based on the likely risk of exposure and means of transmission. So for COVID-19, the recommended precautions currently, as described by the Clinical Excellence Commission in Australia, is that contact and droplet precautions should be used. And the addition of airborne precautions is called for where respiratory AGPs are performed, so they're aerosol generating procedures. Hand hygiene is an absolutely essential element to these practices, along with environmental cleaning and cleaning of shared patient care equipment. So I thought it might be useful to just briefly share with you, I guess, what it means to have contact and droplet precautions and the comparison between airborne precautions. So the first three images on the left indicate, I guess, the protective equipment that might be required or that is required for contact and droplet precautions. And this is a surgical face mask, a gown and gloves. Airborne precautions, the main difference is the addition of a P2 or N95 face mask. And there are obviously a number of really important aspects to the actual use of PPE, and it's not just putting it all on and taking it all off, but the order in which you put it on and the order in which you take it off is very important. The performing of hand hygiene before and after each step is also very important, and particularly important for the use of the P2 and N95 masks is that they fit appropriately, and there's a whole process around fit checking and fit testing that is important to make sure that those masks are used well and do provide the protection, the highest level of protection as expected. So maybe just to say that although it's, you know, on paper it seems quite straightforward, it's actually a relatively complicated process that's important to be well trained in order to get the protection that is expected from PPE. So what's the impact of COVID-19 infections among healthcare workers? Well, certainly first and foremost, the personal health and well-being of the infected individual is key. But perhaps some further impacts include the contribution of their infection towards onward transmission. And as a result of their profession and where they're working, and the number of vulnerable people that may be in contact with them, the workplace becomes a really important setting in which transmission may occur. And also coming home to the household and infecting family, and also contributing to the wider community spread. Healthcare worker infections lead to workforce depletion through their own infection and their need to recover, but also those whom they've come in contact with, and certainly other healthcare workers who are in close contact may require furlough or 14 days of quarantine, and even casual contacts of a confirmed case may require additional prevention measures to be in place to continue work. So it can have a huge impact. One healthcare worker infection can have a huge impact on their immediate workforce. And that of course impacts not only the surge workforce required, but potentially the quality of patient care that's provided through the services in which they work. And healthcare worker infections has also been documented to lead to a loss of confidence on a number of fronts, including confidence in mandated infection prevention and control practices and guidelines, and also in facility management themselves. So I might just move on now to give a brief sort of global perspective. There's certainly a disproportionate number of infections among healthcare workers globally. One report suggested that healthcare workers are 3 to 4-fold more likely to have a positive SARS-CoV-2 test than non-healthcare workers. And the number of healthcare worker infections varies with the stage of the pandemic. Reports from February to April this year, reporting the proportion of healthcare worker cases over the total number of reported cases, suggested that in China early in the pandemic, this was about 4%. In Italy, it was about 11%. In the US, in April, it reached 19%. And there have been reports from the UK and Brazil that the proportion of healthcare workers cases has reached 30%. So quite a wide variety of proportions, but highlighting the disproportionate nature of the infections amongst healthcare workers. And in May this year, the European CDC did an analysis among 15 countries in the EU and the UK, and identified that 23% of reported infections were amongst healthcare workers. So the median number of 14 with a range of 1 to 59. So quite a wide range, but again, highlighting the disproportionate number of infections. Interestingly, they found that although the numbers of infections were high among healthcare workers, the proportion of healthcare worker cases that were hospitalised was lower than those of non-healthcare worker cases, and those that presented with severe illness was lower than non-healthcare worker cases. Healthcare worker infections generally seem to be more among females than men, and the most frequent occupational profession of healthcare workers is nurses. The case fatality rate for men and women is different, with men having a higher case fatality rate of around 9.5 compared to women around 1.5. These figures, I guess, just demonstrate visually some of the information that I've just presented in the previous slide. The map figure showing the predominant, the highest numbers of cases have been reported from North America, from the United States and Western Europe, and also by WHO region, showing that early in the pandemic, up till early May, the European region had the greatest numbers of cumulative cases amongst healthcare workers. So at the time when this report was published, which was May 2020, there were about 150,000 healthcare worker cases reported, which represented almost 4% of the total number of patients worldwide. So it's increasingly appreciated that infection may go undetected and unrecognised among healthcare workers. So a recent convenience sample of healthcare workers at 13 US hospitals reported that 6% had serological evidence of a previous SARS-CoV-2 infection. And incredibly, 1/3 of those did not recall any symptoms. A half of those did not suspect they'd even previously had COVID, and 2/3 had not had a previous positive test. So this report highlights that I guess where community transmission is high, such as it is in the United States, that even with healthcare workers not reporting symptoms or not having a previous test, there's certainly perhaps undetected and unrecognised infection in the healthcare worker population. A published rapid review of the literature from a couple of months ago identified the following risk factors as associated with COVID-19 infection. So a lack of, and not surprisingly, a lack of personal protective equipment, exposure to infected patients, work overload or working more than regular hours, poor infection control practices, and pre-existing medical conditions. Another hospital-based healthcare worker case control study from early in the pandemic in the US identified that longer durations of exposure to an index patient were important. Exposure to aerosol generating procedures, and in this case nebulizer treatments or BiPAP, were important. Prolonged unprotected patient contact was a risk factor, and performing a physical examination, so touching the patient, of course, was a risk. In another study which recruited internationally across 67 countries, non-aerosol generating contact with COVID-19 patients was identified as a risk. With the addition of those who didn't acquire their infection in the workplace, but socialising outside the workplace with healthcare workers was a risk. The use of respirators, so P2 or N95 masks during the conduct of aerosol generating procedures was protective, as was exposure to intensive care or dedicated COVID units and negative pressure rooms. Another hospital-based healthcare worker study in China identified working in a high-risk department, suboptimal hand washing before or after patient contact, again longer working hours, improper use of PPE as being risk factors. And a more recent case control study among healthcare workers from Turkey identified presence of another positive person in the household as a risk factor, inappropriate use of PPE again. And this, I think, is perhaps the first reported risk factor associated with healthcare worker to healthcare worker transmission. But staying in the same break room as a healthcare worker without using a medical mask for more than 15 minutes was associated with infection, as was consuming food within 1 metre of another healthcare worker, and failure to keep a safe social distance from another healthcare worker. A large retrospective prospective study from the UK and the US has suggested a 5-fold increase risk for healthcare workers caring for patients compared to those not caring for patients, even with the use of PPE. And another large retrospective cohort of healthcare workers, and compared to non-healthcare workers in the US, has identified the odds for infection as being similar to those, similar between healthcare workers and non-healthcare workers. They did, however, identify that healthcare workers had a lower odds for COVID-related hospitalisation, and that patient-facing healthcare workers had a higher odds of SARS-CoV-2 infection. So there is a bit of a mixed picture as to what are the specific risks, risk factors for healthcare workers. And I guess they're also understanding that there are a number of limitations with some of these studies, particularly the varying sample sizes, the lack of generalisability of healthcare systems that have adequate access to PPE. A number of the earlier studies were completed when regular access to PPE was more limited. A lot of these methodologies rely on self-report, and there's a limited ability in these studies to adjust for known risk factors of disease, susceptibility and progression. There's lacking data to investigate the relative effects of dual exposure of healthcare workers to COVID-19 in the community versus the workplace. So most of these studies have not been able to distinguish where their healthcare workers actually acquired their infection, but just looking at them more broadly. So given the, I guess, diversity of findings, what are the ongoing concerns of healthcare workers? I mean, certainly early on, and I think still present now, is the major concern is the availability and ongoing supply of PPE. But there's an increasing concern over the effectiveness of PPE and what guidelines should be in place in what settings. Over the period of time of the pandemic, there's been changing and potentially confusing messages to healthcare workers. And with the increased workload that's put upon healthcare workers, there are concerns about the risk of error in patient management and compromised patient care. Healthcare workers are certainly concerned about the ongoing risk to their families and to households and transmission in the community. And as might have alluded to before, there's certainly some level of distrust in facility management. And there's growing evidence and reports in the literature around the impact and detrimental emotional and detrimental impact of COVID-19 to the emotional and psychological well-being of healthcare workers. And just by way of example, from Australia, there was a recent qualitative study that identified a number of themes of concern to Australian healthcare workers. And these included work health and safety standards, concerns around guidelines on respiratory protection, particularly the omission of fit testing for P2 and N95 respirators, deficiencies in the availability, quality, appropriateness and training of personal protective equipment, and concerns around workplace culture that perhaps enable and promote bullying in response to concerns about safety. So I'm not touching more on this aspect, but just to note that this is obviously an area of great concern to healthcare workers and should be part of the response, not only just an investigation of where healthcare workers have acquired their infection. So I might just now move on to the circumstances in Australia. And just to say that I think probably everybody in the audience is familiar with the pandemic in Australia, which is, I guess, somewhat unique, and you know, we're in some ways quite lucky to feel quite in control of the epidemic here. 2 waves of the epidemic. We're coming out of what looks like the tail of perhaps of the second wave. And just to note that in Australia there's no national reporting of healthcare worker infections yet, although there is movement towards doing that. So the next number of slides I'll take you through are related to healthcare worker infections in Tasmania, New South Wales and Victoria, which have contributed the majority or all of the healthcare worker infections in Australia thus far. So in Tasmania, you may recall that in April 2020, there was an outbreak of COVID-19 among healthcare workers in northwest Tasmania at a number of facilities. There appeared to be 80 healthcare worker cases in total at the end of the outbreak. And it resulted in a significant period of furlough for all healthcare workers who were working in the facilities in northwest Tasmania. The facilities were managed by I think the ADF, and this epi-curve, I guess, kind of demonstrates the time axis along the bottom and the number of cases on the vertical axis. There are a number of transmissions of pathways, including patient to healthcare worker transmissions, but also clusters of healthcare worker to healthcare worker transmissions. The initial cases that you can see in that epi-curve originated with one or two patients that presented to the hospital, and then subsequently resulted in ongoing transmissions between healthcare workers and also to some patients. The transmissions occurred across a variety of settings in these facilities, including the medical and surgical wards. There was a mental health ward involved. The emergency department was, I guess, the initial place where the patients were admitted, and there was a cluster identified there, and also in the operating theatres. So what were the factors that were identified that may have enhanced transmission in the northwest Tasmanian outbreak? Well, certainly staff, it was identified that staff were attending and continuing to work while symptomatic. There were a number of workplace activities where physical distancing wasn't observed, and these were predominantly things like ward rounds and healthcare worker meetings. There were some limitations identified in the infection prevention and control practices in the facilities, and a delay in identification of close contacts of confirmed cases was also thought to have enhanced transmission. Significantly, there were high levels of staff mobility between the facilities, and also transfer of undiagnosed patients between facilities, which enhanced transmission. And some of the actions that were taken as a result of the identification of these factors included the strengthening and optimising of infection prevention and control practices in the facilities. There were procedural changes to strengthen the physical distancing in the workplace, and there were a number of strategies to address the drivers of presenteeism, and also the implementation of healthcare worker screening, including asking of symptoms before returning to work. And there was a reduction in movement of staff and patients between hospitals. So that the Tasmanian outbreak, I guess, was the first in the timeline. I guess things came together in a very detrimental way, and there were, this was the first and the largest outbreak of healthcare workers infections in Australia. In New South Wales, in fact, from the early stages of the pandemic in Australia, there was relatively limited routine capture and reporting of data around healthcare worker infections. However, from about March onwards, processes were developed by New South Wales Health to be able to conduct more enhanced investigation of healthcare worker infections. And this included a healthcare worker investigation protocol, the development and administration of a healthcare worker specific questionnaire, in addition to the initial case investigation questionnaire, and focused on questions around infection prevention and control practices and behaviours, and an expert panel was convened to review healthcare worker infections and provide advice to the investigators, and also to rapidly disseminate any learnings locally or statewide. These enhanced investigations are led by the Public Health Unit within the LHD in collaboration with the health facility infection control practitioners. So it's led at the local level with information captured at the ministry level. So in New South Wales, it's probably important to share what the definition of a healthcare worker is. And that's certainly, for New South Wales, that's all paid and unpaid staff currently working in healthcare. So it includes and captures information around clinical but also non-clinical staff. It explicitly excludes aged care staff unless they're working also in another health facility. And a retrospective review was recently completed for the period of February through July this year, which covered the first wave of the epidemic in Australia. And routine data was extracted from the notifiable infections database called NSIMS, which is in New South Wales, with further input from the public health units. There was consideration made of the epidemiology of the case and also the laboratory data, including whole genome sequencing where it was available, and with input of the expert panel to ultimately determine the likely source of acquisition for each infection and the direction of transmission. So for the period of February through July, there were a total of 3,584 reported COVID infections in New South Wales. And among those, 206, almost 6%, were identified as healthcare workers. Of those 206 healthcare workers, almost 40% were identified as having acquired their infection either overseas or interstate. About 20% were known to have acquired their infection as a result of a contact with a household or community member or as part of a community cluster, which left about 86 healthcare worker cases where the source of infection was unknown and thus potentially could have been health facility acquired. So among those 86 potential health facility acquired cases, the mean age was 41 years and predominantly among females, 67% of those were female. The majority of the infections were among clinical facing staff, majority being nurses, 36% nurses, doctors 21% and other allied health staff 10%. Support staff represented about 21% of cases and included administrative staff, those providing pathology services, operating theatre assistants and cleaning staff. So in order to determine the likelihood of infection acquisition within the health facility setting, we applied these principles to each case. So a likely healthcare worker infection was where there was clear epidemiologic and or laboratory evidence of an exposure to a case of COVID-19 in the workplace. A possible health facility acquired case was where there was perhaps suggestive epidemiologic or laboratory evidence, but no direct exposure identified. An unlikely health facility acquired was where there really was no epi or lab evidence of exposure, and it could have been equally likely that somebody might have acquired their infection in the community. So this table shows the final determination of acquisition of infection with 39 of the 86 determined to be likely acquired in the health facility setting. So that's almost half. About 20% were thought to be possibly health facility acquired, with about 30% being unlikely to be health facility acquired. So 50% of these infections acquired in the workplace were actually associated with known health facility clusters, so strengthening the likelihood that they were acquired in the workplace. And most of these infections occurred quite early on in the pandemic and were so associated with an unrecognised source patient. So early on in the pandemic, where a patient may have come in with symptoms other than that was suspected for COVID-19, they would have been attended to with transmission precautions that were perhaps in hindsight not adequate. So some of the key issues that have been identified through the review of healthcare worker cases by the expert panel include the need for ongoing training and infection prevention and control, including the donning and doffing. The need for appropriately skilled staff to care for patients with suspected or known COVID-19. And that there needs to be further mitigation of risk in shared workplaces, including the adequacy of environmental cleaning, physical distancing and hand hygiene and appropriate PPE use in these shared spaces. So since August, there have been 18 healthcare workers with who were potentially infected in a healthcare setting in New South Wales, and 16 of these have been associated with 4 clusters in a healthcare settings. 2 have been from Hornsby, 6 from Liverpool Dialysis Unit. It's been 1 from Liverpool Emergency Department, and 7 from Concord Hospital. And of note, during this second wave of healthcare worker infections, most have been required as a result of interactions with infected colleagues rather than patient to healthcare worker transmission. Regular updates are now available through New South Wales Health that document ongoing healthcare worker infections. And maybe just to finish off, to touch on what's been going on in Victoria, here's the epi curve for healthcare worker cases over time, and most of you would be aware that there'd been a big surge during the second wave of infections in Victoria, particularly amongst healthcare workers. During the first wave, 22% of healthcare worker cases appeared to have acquired their COVID-19 in the workplace, so similar to the New South Wales picture. But in contrast, during the second wave, 70% of healthcare worker cases have acquired their COVID-19 in the workplace. To note particularly that the Victorian data includes aged care workers within their healthcare worker case count, so that's quite distinct from New South Wales. The most recent data from the most recent days indicated that there are a total of over 3,500 healthcare workers who have acquired COVID-19. About a half of those have been in the aged care sector and a third in the hospital sector. And again, Victoria provides now regular updates through their DHHS website specific to healthcare worker infections. One of the largest outbreaks, and in fact, I think it's certainly the largest institutional outbreak, it was at the Royal Melbourne Hospital during July and August this year. They identified 262 healthcare worker cases with COVID-19 in their outbreak, and the majority were among nurses and then support staff, followed by doctors. They identified clusters of infection having occurred on the wards with known COVID-19 patients, and they also reported a large influx of cases from nursing homes who came into the hospital, I guess, increasing that density of exposure for healthcare workers. Staff infections peaked when the COVID-19 infected inpatient numbers were also highest, and those infections and clusters predominantly occurred upon the geriatric and rehabilitation inpatient wards. Those that were part of the outbreak and in the response to the outbreak identified that the availability of rapid turnaround of staff testing and the regular review of local data and feedback from staff was really important to help identify interventions which helped interrupt the outbreak in this particular facility. And they also highlighted the need to pay attention to staff wellbeing as a critical part of the response, and comprehensive support service was implemented as part of their response. So just aware that time, we've just got a couple of minutes left, are probably quite good. I'll just briefly touch on the future, what the future might hold, the immediate future and perhaps the longer term future. I mean, it's certainly clear to me from, I guess, my rapid upskilling in understanding healthcare worker infections and COVID-19 that, you know, it's important to continue to investigate and document infections in healthcare workers. And I'm really pleased to see what's been developed certainly in New South Wales through my secondment there over the last number of months, the infrastructure and the ability to respond and investigate these infections now very rapidly. And so we've got a very robust infrastructure, I think, in place to continue to investigate and document infections. And I think as part of that, there should be complementary research to gain further insight and identify transmission and infection risks. I think from some of that earlier data that I presented from the global perspective, you know, the setting is important, and you know, Australia is quite different to other places, and we need to understand what's going on in our own facilities and our own context in order to make sure that we're providing the best evidence-based practice guidelines to protect healthcare workers in Australia. And I'm pleased to sort of say that you know, there is movement towards doing some complementary research. There's a cohort study that's been completed as part of investigating the Northwest Tasmania outbreak, and includes a quantitative, qualitative and serological components to the study. There are a couple of case control studies, one in New South Wales that I'm involved with, and one ongoing in Victoria that hopefully should provide some information to further inform guidelines. And there's also, I noted, a study either about to launch or recently launched and led by Monash that's looking into long-term impacts of the pandemic on healthcare worker psychological and physical wellbeing. And all of these findings and learnings need to be rapidly disseminated and used to inform the guidelines. And an area that I haven't even touched on, but I'm interested to learn a bit more about, is sort of other research trials that are, you know, obviously involving vaccines and perhaps other medical prophylaxis that'll be really important to consider to protect healthcare workers and the broader community. And with that, I'll thank everybody for their attention, and very happy to answer any questions as I can in the remaining time.
Thanks very much, Louise. I think everyone listening to you would fully appreciate that was a fabulous talk, comprehensive, considered. I think it touched on so many points, and I'm sure you could speak about this for hours in terms of some of those topics. And I think many of us have learnt a lot. Just one particular point, I think most of us would probably be unaware of the number of cases in Australia which were healthcare workers. So I think it was interesting you made the point that at a state level that data is being collected and increasingly so, but there's a move to get that information available nationally. So I think that's really important. So we've got 10 minutes, well actually 8 minutes remaining. So I won't take too much time up with my questions, because I can ask you afterwards. But I'll open it up to questions that have been asked by people participating. There were a few questions, direct questions, I guess, clarifications, which relate to exposure. So just, I guess, two related questions. So David Allen, who's on the seminar, has asked, I guess, about how you define direct exposure, and then also asked the question about, I guess, in terms of control strategies, what about improving ventilation? If you wanted to comment on both those ones.
Yeah, thanks, Beck. So with regards to exposure, I guess it's an area I've thought quite a lot about, and exposure, the term exposure, I guess, is kind of thrown around in the literature, and certainly in studies is defined quite differently. From the perspective of a risk assessment for contact tracing, you know, exposure is a combination of sort of physical distance from a known source case and a time period. So direct exposure sort of feeds into whether somebody might be a close contact. So direct exposure, I guess, can be, might be considered physically touching a patient or a patient's immediate surroundings. But it could also be that you're within 1.5 metres of a known source case and a certain period of time. So there are a variety of ways to define exposure. I guess indirect exposure is more focused on where you're touching the belongings or immediate environment of a source case, whereas direct exposure might be physically hands-on or within, touching the source patient. But there's quite a range of definitions of what an exposure might be, and that's quite important in terms of understanding the findings of research studies and so forth. And the second question around ventilation, I mean, I actually don't know that much about ventilation, only that it is important, clearly, and particularly with the growing evidence around airborne transmission. It's one of those things, I guess. There are some hospitals have ventilation systems in certain rooms that potentially are better or pose lesser risk for healthcare workers, for example, perhaps a negative pressure room. But I think the general literature is sort of talking about ventilation is that a lot of hospitals are quite old and poorly ventilated, and certainly a lot of the spaces where healthcare workers gather with each other, such as tea rooms or meeting rooms, are often the most poorly ventilated places and are often just corners of areas. So it's a really important consideration, but often not something that can be easily controlled or changed.
Thank you, Lou. So I've got another question which actually relates to the definition of a healthcare worker. So the question was, does healthcare workers include volunteers in hospitals? And I think you touched on that, but it'd be also interesting to know, are there guidelines specifically for volunteers, and do they differ from actual people working in sort of a more clinical role?
Yeah. It's interesting. The definition of a healthcare worker seems to vary again between jurisdictions and countries and studies, and the immediate, I guess for New South Wales, the discussion around who to include was trying to be based upon more, I guess, the setting and who might be at risk in the setting, and considering, well, there are people who do volunteer, who come into the space and may not be paid employees of the hospital. I don't know about differing guidelines, and it's a good question. I mean, the same goes probably for cleaners and other support staff who are sort of sometimes outside the immediate. They have a different sort of hierarchy within the hospital and a different way of being appointed to certain settings as well as part of their job. Yes, it's. I mean, the big difference, I guess, that I've noticed is more around whether to include aged care workers in the healthcare worker count. And obviously there's a big distinction in what Victoria's done versus New South Wales in terms of their counts. And that distinction was made because the health facility settings and the staff that work in those are quite different in terms of their training and their expertise than aged care settings and residential settings. That doesn't quite, I've sort of gone a little bit off track, but it doesn't quite address the volunteer. But the idea was to be as broad and setting based rather than profession based in terms of our counts.
Thanks. So it sounds like there might be some information out there, but it's quite an interesting area about who gets included in the definition of healthcare worker and the implications and control measures. They could vary a little bit. And so there's just a couple of questions which relate to everyone's favourite topic, which is aerosol transmission. And I won't read out the questions specifically, but just summarise a couple of the questions. I guess the inquiry is about increasing recognition of aerosol transmission and acknowledging that in hospitals there's, I guess, certain masks which are recommended according to that exposure risk. So I guess with that increasing knowledge of aerosol transmission, does there need to be, I guess, any change in the guidelines or the practices within hospital in relation to that information?
No, thanks. It's quite a topical question, I guess, and it's to the crux of, I think, a lot of concerns for healthcare workers. You know, I guess my hearing of the discourse around this through experts in infection control and infectious diseases is that the decision, I guess there's a group that evaluate the evidence and then provide the guidelines for Australia. And at the moment, you know, that the use of the N2 P95, the P2 N95 masks is reserved for those doing aerosol generating procedures, but also extends to circumstances where patients might be infectious but combative, or perhaps unable to be managed in a way that reduces the risk for the healthcare worker. So I think there has been a bit of a broadening of the circumstances in which those aerosol airborne precautions are being used. But underlying that, there seems to be concern. The masks will only be as effective as they're purported to be if they're used in the way and they fit well and they're fit checked. And I think some of the concern is that actually a medical mask or a surgical mask provides better protection than an N95 mask if the N95 mask is not actually fitted to the person's face. And I think there's a whole sort of area around which there needs to be some additional thought and perhaps evidence too, that, you know, healthcare workers are able to use and have access to some of those trainings and fit checking and fit testing ahead of using the mask, because a poorly fitting N95 mask will protect you no better than a medical or surgical mask. So I think there's still a way to go with that. I think the evidence, though, is being reviewed, I think, regularly, and, you know, I think the guidelines adapt with the evidence that's available. So I think it could well change, and I think, you know, anything that we can contribute through complementary research as well around this and the effectiveness of currently used guidelines and applied PPE will help inform that decision.
Thanks, Lou. I think we need to wrap up, but there was just one final question from an anonymous person on the seminar who is interested to ask about the Kirby Institute's role, or your role in all this in terms of healthcare worker, I guess, investigations or research or surveillance. If you wanted to finish off by summarising, I think you did touch on it, but if you wanted to elaborate for the audience on how, I guess, you or others are contributing to this, sounds like a very important issue.
Yeah, thanks. Maybe just briefly, I mean, myself and a number of others from the Kirby, I guess initially were involved invited by New South Wales Health to assist with healthcare worker investigations. You know, it was initially, I think, sort of a role that might have been more a research role, but as things kind of developed and kind of just working with the response, it became clear that there were some gaps in the ability to do investigations of healthcare workers, and so the Kirby's been supporting New South Wales Health to develop some of the protocols, certainly the questionnaire that's being used, and to support the convening and running of the expert panel, and there's now, I guess, sort of a well-established process, and now really great to see some regular reporting and regular capture of data at the sort of state level, and also contributing, I guess, to that sort of process towards national reporting, which, you know, when you say, well, how many healthcare workers in Australia have contracted COVID? I mean, you can't find, it's not there. You've got to kind of, and then there are differences between states. So it's been I mean, for me, it's been a terrific opportunity to be involved in the response, and something that I've, you know, exponentially learned. So I'm sharing what my knowledge is now, but there's certainly a lot more out there, and perhaps, you know, there are others who could contribute to the learnings and findings as well of all of the work. Thanks, Beck.
Thank you, Louise. And I know there's, I mean, Raina and many others have been doing work, I guess, in the area, Raina particularly in the area of masks, which has obviously contributed to this topic. And as you mentioned, surveillance and the case control study, and there's probably others as well. So just, I guess we'll finish up now. I didn't quite answer all the questions, but I encourage you to contact Louise directly if there's things I didn't raise in the interest of time. But just a big thank you, Louise, for a great presentation again. And thank you, everyone, for participating. I think it was a very important topic, and it was good to receive this lovely summary from Louise, and I'm sure there'll be follow-ups with you, Louise, with certain questions, and perhaps you know, maybe some areas that are further collaboration between people within the organisation and outside of the organisation. So thanks very much, everyone, and look forward to seeing you at the next seminar. Thank you.
Thanks very much, Beck.